Today we are going to talk about stepwise devascularization or systematic pelvic devascularization. So hemostasis is the mnemonic for management of postpartum hemorrhage, where the stepwise devascularization or systemic pelvic devascularization is done after the medical management, tamponade, and usually after compression sutures. It includes unilateral uterine vessel ligation, bilateral uterine vessel ligation, bilateral low uterine vessel ligation, unilateral Utero-Ovarian Anastomosis Ligation, and bilateral Utero-Ovarian Anastomosis Ligation. For uterine vessel ligation, we will first exteriorize the uterus. The assistant will stabilize the uterus by stretching it upwards. The bladder is pushed down and protected with a Devas retractor. The bowel is protected by packing with a mop behind the uterus or by placing the four fingers of left hand behind the uterus, like shown here. Now the uterine artery is palpated and we take a vicryl number 1 suture which is passed about 1 to 1.5 centimeters below the uterine incision and 1 to 1.5 centimeters medial to the lateral edge so as to incorporate some myometrium. We are going to come out through the clear avascular area in the broad ligament. Before we tie the suture, we have to check the posterior surface and we have to ensure that no bowel, mop or glove is incorporated in our suture. Once we have ensured that, we are going to tie the suture, secure it, and our uterine artery ligation is done. Now, when we want to ligate the uterine vessels of right side, we have to reposition ourselves in such a way that we are facing the face of the patient, and hence the ligation of the right side of uterine vessels becomes easier. The procedure is same as is followed on the left side. The low uterine vessel ligation is done in a similar manner, ensuring that the bladder is low, and we take the ligature 2 to 3 centimeters below the uterine vessel ligature. This is repeated on the opposite side. This is particularly useful where the PPH is due to placenta previa. For Utero-Ovarian Anastomosis Ligation, we are going to identify the fundal structures. An assistant will lightly stretch the fallopian tube. At all times when we are going to suture, we are going to stay below the fallopian tube level. So what we are going to do is we are going to insert the needle slightly medial to the lateral edge of the uterus between your round ligament and the fallopian tube, and we are going to exit posteriorly between the fallopian tube and the ovarian ligament. Now we are going to come out anteriorly again below the level of the fallopian tube from the avascular zone in the broad ligament. So in this way, the fallopian tube is not included in the suture. The suture is tied. This is repeated on the opposite side.